test, check, check, hello, check, test, check, 1, 2, hello, test, check, check, mic test, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 19, hello, test. Hello, test, check. அதே போய் நேருங்க. Hello, test, check, mic test, 1, 2, test, check, test, check, 1, 2, test. Test, check. Your Hello, test check 1 2 3. Hello, test check. Hello, check check. Hello, check. Hello, test check. Hello, check check. Hello. Hello. Stage on la da on la
Good afternoon, everybody. Today's webcast is a case discussion to be which will be presented by Dr. Mallesri, our DNB PG. The discussants are Dr. Suresh, our junior consultant, and Dr. Venkateswari, and I'll be the moderator. Okay. And will you be able to bring the patient, Dr. Mallesri? Yeah. Dr. Mallesri will start discussing, but in between I would request the students here to participate in an interactive manner. You can ask questions, you can stop Mallesri or Dr. Suresh or Venkateswari or me when we are discussing. Let it not be a discussion only between Mallesri and the three panelists, right? Okay, over to Dr. Mallesri.
Good afternoon. I am presenting the case details of Mehraj, a 13-year-old adolescent girl, hailing from Chennai. Informant is the mother, whose history is reliable. Mehraj, who was school-going adolescent girl, was brought with the chief complaints of cough for 3 weeks, breathlessness for 10 days, and loss of weight and appetite for the past 1 month. Mehraj was apparently well, school-going child till 1 month back, when the illness initially started as low-grade intermittent fever of 2 days duration, not associated with any chills and rigors. The fever subsided with oral medication within 2 days. This was followed by onset of cough, which lasted for the past 3 weeks, which is progressively increasing in nature, severe for the past...
Sorry for interrupting you. Sir, the presenting chief complaints, what you elaborated is, here is we have an adolescent girl presenting with cough of 3 weeks, breathlessness for 10 days, and
loss of weight
for 1 month. Any comments from the audience? Yeah, very important is chief complaints. The order of presentation should be based on the chronological order. For example, if
3 weeks, it has progressively increased and it is interfering with her activities. Cough is predominantly present in the early morning. There is no postural variation with the cough.
So, postural variation in cough. Okay, this child, there is no postural variation. Okay, if the same child gives a history, why you are getting this history first of all? Let me know.
Causes of cough, whether it is respiratory or CVS cause.
No, the postural variation. We are now analyzing the cough as a presenting symptom. In this case, there is no postural variation. You are asking in history whether the child is having postural variation or not. So postural variation, why this history is important with relevance to cough?
Bronchiectasis.
It will identify the etiology or what?
Side of...
Yeah, it has more localizing value. Okay, that is what we are asking. So by asking the symptoms in detail, we want to localize the pathology where it is and try to identify the etiology. That is the ultimate aim of taking a detailed history. Okay, so here there is no postural variation is there. So if a postural variation is there as a presenting symptom, we would like to think as, for example, a child complains that she has a pain, cough more when she turns to the left side, then the lesion will be most probably on the right side. So it's a lesion localizing value. Okay. So another thing what she told is, cough initially was not disturbing the child activities. What child activities have been disturbed?
She has been not going to the school for the past 15 days, unable to do her daily activities.
What about her sleep?
It is not disturbed by coughs.
Okay, sleep is not disturbed by the cough. Okay, so if a cough occurs predominantly in the morning here, okay, the same cough occurs only in the night. See, here we have an adolescent girl who is presenting with 3 coughs. The scenario is little different. I am not going a little away from the case. So if a child has a cough with 3 weeks duration, occurs only in the night. Why I am highlighting this is, what is the use of asking whether any diurnal variation? Okay, that is only more important. Okay, cough which is happening only in the night. What is the possibility?
Allergic, like asthma.
Predominantly in the night. So postnasal drip or bronchial asthma. In a similar situation, if a child cough happens not only in the morning, not in the night, what is the possibility? Yeah, being an adolescent girl, psychogenic cough would be considered. It's a diagnosis of exclusion. Okay. So any other history you would like to add?
It is not associated with chest pain, sir.
Okay.
Cough is.
I think there are 3 or 4. There is a pathology, there is anatomical lesion in whooping cough.
Airways.
Airways, isn't it? Airways, isn't it? Right, 1.
Barking type of cough.
Barking, child is, in fact just now, about 45 minutes back in the OPD, I asked my PG, what is the nature of the cough and where is the lesion? So it's very characteristic. What is that?
Croup, laryngitis.
What type of cough you get in croup?
Barking type
Barking, it's like a dog almost, right? The barking cough will tell you that the lesion is likely to be in trachea. Can you give some other examples of cough which will tell you where the lesion is?
Staccato cough.
Staccato cough. Does it? What is staccato cough? Can you simulate staccato cough?
I am not sure, sir.
Not sure. Anybody can simulate staccato cough? Just what is staccato cough? Huh? Can you mimic staccato cough, Ashwin?
It's like
What does that tell you again? Where is the lesion? Anatomy. Where is the anatomy in staccato cough? Is it upper airway, lower airway? Upper airway or lower airway. It can be anything. Right? Staccato cough. And which condition? So-called books describe staccato cough as chlamydia pneumonia. That's what books say. I don't know how characteristically one can diagnose only based on staccato cough. Studies have shown it is not the specificity and sensitivity of staccato cough for diagnosing chlamydia pneumonia is very low. Right? Some other example? Suppose somebody is coughing, you don't hear anything. Coughing, no noise is coming. Where is the lesion? Where is the lesion?
Vocal cords.
Child is coughing, you are seeing the child coughing but you are not hearing anything.
Vocal cords.
Vocal cord, obviously it's a laryngeal lesion, isn't it? Ineffective cough, right? Similarly, if you have a child who has a vocal cord paralysis, what happens to a cough? You won't hear anything. It's ineffective cough. Huh? That's all. Child won't produce any noise and you will see that the child is not able to bring up the secretions. Right? Or not able to move the secretions up. Ineffective. You can get in vocal cord paralysis or a child who has got respiratory muscle weakness. How will be the cough? Absolutely ineffective, isn't it? Ineffective. Right? And can you get musical cough? Can you hear a Musical cough? Yeah, a child with wheezing can sometimes you can hear the wheeze itself during the end of the expiration. It will tell you that there is obstruction in the intrathoracic airways and the obstruction is predominantly expiratory. You can diagnose asthma if you are lucky to see that. Because you may not get the typical cough in young children. Isn't it? What else? What else? If you find a child is bringing the roof down and hearing, you are sitting in your OPD, the corridor, you are able to hear somebody coughing non-stop. Non-stop. It's an attention-seeking behavior. Suresh mentioned, child who doesn't cough, one question will sort out the issue. You ask them, is the child coughing in the night? They say no. But in your corridor, in your waiting room, in the OPD, the child keeps on coughing non-stop. The pattern of cough is something which will draw your attention that this is, the child is producing the cough voluntarily. Isn't it? And of course, you must also remember the cough will also tell you whether there are secretions in the respiratory tract or not. How will you identify? How will you identify that there are secretions, accumulated secretions in the respiratory tract? Anybody? It's an absolutely wet cough. I don't know how many of you have heard the term called persistent wet cough. What is that? What is that? Anybody? There is a syndrome itself called persistent wet cough in children. Anybody can tell me what it is? It is a syndrome described where you have moist cough in children persisting over 4 weeks. And studies have shown by investigations that these children have transient bronchiectasis. The average called persistent plastic bronchitis. That's the terminology used in literature. And now the terminology has now come to be accepted, and it is believed that these children do respond to a 2-week course of antibiotics, preferably amoxiclav. This has been described well in literature. In fact, there is a nice article in Thorax on this. Right? It's called persistent wet cough. Children coughing. You don't find anything. You may get crackles, but these children have a wet cough. You know the child has respiratory secretions in the bronchi, accumulated secretions. Wet cough. In fact, even in children with bronchiectasis, you will hear this wet cough. Wet cough. Right? And the pattern of cough is going to localize, whether it is up. It's a hacking cough.
Postnasal drip.
You know it is postnasal drip arising from the upper respiratory tract. So these are all the ways you can identify. In this child, what has happened? You said the cough is worsened, the cough is moist, and you said the cough is... She is bringing out expectoration. So, yes, all this tells you that this child's lesion is in the lower respiratory tract. She is not able to localize, it is bilateral. And there are obviously secretions in the lower respiratory tract because there is expectoration. And most importantly, what else is the conclusion from her history? She says the child has not got better. What does that tell you? It is a progressive disorder. Simple. This disorder, for whatever reasons, is not improving. Progressive disorder of the airways with secretions, which is not improving. Because one other condition other than what Suresh mentioned is asthma, and he mentioned postnasal drip. Any other cough which is nocturnal? Characteristically nocturnal?
Cardiac.
Remember, cardiac disease per se as a cause for chronic cough is unusual. It's unusual, right? GERD, gastro is a nocturnal cough. There are only 3 conditions in adults or pediatrics which cause nocturnal cough: asthma, postnasal drip, and GERD. And even in children with bronchiectasis, early morning cough and expectoration is very, very characteristic. Right?
Breathlessness was insidious in onset, has been present for the past 10 days.
Also mention whether the cough is associated with breathlessness, persistently, intermittently, following the cough. For example, a child who has a prolonged cough may be breathless for a few minutes following the bout of cough. Right? But that's not very sinister. On the other hand, if there is persistent breathlessness, in addition to cough, it gives you a different meaning. Isn't it? That means, definitely this airway disease is actually causing some disturbance to the physiology. Breathlessness will not come in a child with a respiratory problem unless there is severe obstruction or hypoxia. You can't get it otherwise.
Regarding the sputum, does it give us any clue? You said that the child brings out expectoration. So, is it really useful in any way? Is it common to have expectoration in pediatric age group? It is not common. Generally, children who are less than 5 years of age, they don't bring out expectoration. So, they always swallow the expectoration. So, here we have a 13-year-old girl who is able to bring out sputum. So, this history is very typical because she has a moist cough with expectoration. So, does it give you any clue, this expectoration?
It can be present in tuberculosis.
Yeah, like in what way does it give you a clue? Based on the quality as well as the quantity. Okay, so the quality, like we are talking, you said the color. The color, you said it is yellowish in color. And what about the quantity of the expectoration?
Few teaspoons.
Yeah, so it is like, it's like almost a handful, like that's what she's trying to tell. So, what does it tell you? Does it add more
activities? And this is associated with fast breathing, observed during rest as well as during activity. There is no history of any diurnal variation. It is not aggravated by lying down or on lying to one side. There is no history of chest pain associated with the breathlessness.
Breathlessness it is associated with fast breathing. What is the difference between fast breathing and breathlessness? Is there any difference?
Being aware of one's effort of breathing, or difficulty in breathing is breathlessness, sir.
See, a child presenting with breathlessness, okay, with history of breathlessness of 10 days duration, previously well child. So what are the possibilities you would like to keep in mind?
Airway disease, sir.
So it could be respiratory, okay,
or cardiovascular.
Cardiovascular. Now come to respiratory. This child has a cough, now presenting with breathlessness. Then what are the possibilities?
In this child, sir, or in general?
In this child.
So it's a progressive.
So it is an upper respiratory problem or a lower respiratory problem?
Lower respiratory.
So it is a lower respiratory problem. So lower respiratory could be, as sir already pointed at you, it may be airway or parenchyma or pleura. See, why I am telling you this, you have to get
loss of weight and loss of appetite, on and off fever, undocumented low-grade fever with a chronic cough of 3 weeks duration. So what are all the possibilities which you can, don't just stick on to tuberculosis because tuberculosis is common in our country, but we are thinking of a adolescent girl who's present with this problem. So what are all the possible DDs that come to your mind when you have an adolescent girl with prolonged fever?
Acquired immunodeficiency.
She is thinking of immune deficiency, possibly an acquired immune deficiency. Then
bronchiectasis.
Bronchiectasis. Why are you saying bronchiectasis? Because of the history, chronic cough and other things. Okay. Like, is there a like I'm asking you a broad classification. Like you said, tuberculosis, bronchiectasis, everything will come under an infective etiology. Anything else?
Autoimmune.
So somebody wants to, because it's an adolescent girl, it just comes to our mind. Okay, it can just be a presentation of an underlying autoimmune disorder. Anything else?
Inflammatory. Whether it is malignancy.
Yeah, malignancy. Because it is an adolescent girl who's come with a chronic history and an undocumented low-grade fever. Can we categorically say that this is not malignancy and leave the child?
No, we cannot.
It is not. So it's like, so in what way does fever give you a clue? What are all the types of fevers?
Continuous, intermittent, remittent, relapsing fever.
Relapsing fever. Okay. Then what other types of fever do you know? Pellepstin type of fever. Then
stepladder is a pattern of intermittent fever.
Yes. biphasic febrile illness. Can this be infectious mononucleosis or something, a chronic history? Unless you go to her examination, you should keep your minds open. Okay, so the way the mother is describing the fever doesn't fit into any pattern. Okay, but any other history should you ask with the fever? Now that you are like almost convinced that this is evening rise of temperature, you're kind of telling, you didn't tell the statement that it's the evening rise of temperature, but you said that it's more in the night, it is low grade, and you're thinking of tuberculosis. Any other symptoms should you ask which will add more to the...
Any rash during the time of how is the
Can
child
fever be associated with any systemic symptoms in tuberculosis? Any other systemic symptoms? Yeah, are there any history of night sweats? Okay, what happens in Pellepstin type of fever? Even in a Hodgkin's lymphoma child, they can have fever, prolonged fever on and off, and they can have night sweats, they can have weight loss, they can have loss of appetite. Okay, so it's like whenever you tell your history of fever, you said the pattern of fever. So that's where she's very clear. It is intermittent fever, it is a low grade fever, it's not a documented fever. Was there a response to antipyretic? Was the mother giving antipyretic every time when she felt the child was warm?
Initially she was giving, later
it did not require antipyretics also. So do we need to have definite high grade fever in a child with tuberculosis?
No.
Or do we need to have this definite evidence of evening rise of temperature in a child with tuberculosis?
No.
It's not. It's usually more descriptive in an adult. Okay, whereas when it comes to children, it is not the classic pattern. Okay, you can have child who comes with tuberculosis without any documented fever. But generally, if you ask, the history will be non-specific. They will say the child has low-grade fever, intermittent fever, and most of the times it will not be documented. Okay, and coming back to weight loss. So here, what do you think, is the weight loss significant or not significant? Because generally, our Indian mothers, any mother you ask, they will say the child has lost weight, and any mother will say the child has lost appetite, doesn't eat much. So how do you categorically say that this is a significant weight loss?
In the presence of documented weight, if it is more than 5% of the maximum weight in the last 3 months, then it is significant weight loss.
So that's what. So you suppose you have a child and the mother has a documented weight, and which is the maximum weight in the last 3 months. Whatever is the maximum recorded weight in the last 3 months, and if the present weight is, there is a 5% drop in the weight, then it is a significant weight loss. So this is when you have a child with documented history, where they have a documented weight history. Otherwise, like what sir said, like you should try to elicit more history, asking about whether the clots have loosened and what other history can you get. Okay.
Again, you must tell me whether the fever is coming down, remaining the same, or is worsening.
It has been the same, sir.
It has been the same. I think that's very important. I might ask the audience, why is there evening rise of temperature, the classic evening rise of temperature in tuberculosis? What is the pathogenesis of the evening rise? Can anybody tell me? It is nothing but the exaggeration of the normal diurnal variation. Remember, all our body temperatures are low in the morning, cortisol levels are high, evening temperatures are down, temperatures are up, and cortisol levels are down. And tuberculosis is again a cytokine response which makes the diurnal variation more obvious, right? The other important thing that you must know is that only based on the pattern of fever, you very rarely make a diagnosis, very rarely. But of course, can somebody give me which fever charts straight away will tell you that the diagnosis? Can you give a few examples?
Malaria.
Yeah, malaria. Obviously, child is absolutely well. One day, tertian fever or quartan fever, you're going to think of malaria, isn't it? Right? Then? Biphasic? Yeah, biphasic fever is going to tell you that it is maybe dengue or it may be viral. Very good. Any other illness where you can look at the temperature chart and say, only? Yeah, what does it tell you? What does that tell you? Nighttime fever, daytime no fever.
Connective tissue disorders.
Connective tissue disorder, what type of fever? Which connective tissue disorder you are going to diagnose looking at the temperature chart? You can't, is it? You can't. Pardon? No, actually in rheumatoid arthritis or SOJ, there is very high fever sometime in the afternoon and which returns to normal after some time. Comes like that. And if you look at it, it will be like this. Right? In a child who has got prolonged fever, the fever comes down abruptly, and at the height of the fever you may get a rash. Fever will come down. Child will be well in between episodes of fever. A rheumatoid arthritis. Sometimes you can diagnose typical. Even in Nelson there is a chart of a child with rheumatoid arthritis, temperature chart, old edition. Exactly like this, coming for a few hours and then say very high fever, then settling down, and child completely normal in between. Daily. Only thing is it doesn't happen like malaria. That can give you a clue. And of course, suppose child has fever only during daytime, then there is no fever at all in the night. No fever. Toward the evening, settle down. Yeah, it tells you that it is probably a non-inflammatory, non-infectious cause like your ectodermal dysplasia. For example, during the summer months, these children will get fever only during the daytime. Night time there may not be any rise in temperature. Particularly if you get a history that there is no sweating, that will give you a clue that it is a autonomic cause for fever rather than a cytokine-induced cause of fever.
It can be chronic malnutrition.
No, you said this child has swelling of legs, okay? So, one child definitely has edema. So, how do you find out what is the cause of edema in a child? Generally, how do you, what history? You told us negative history, right?
Yes.
So, what all does it rule out?
So, it is not a cardiac cause of
Why
edema.
is it not a cardiac cause?
It is not associated with any facial puffiness, abdominal distension. There is no history of decreased urine output. There is no history of orthopnea.
Yeah, main history is that, okay. Even in cardiac edema, early edema, you can just have edema in the dependent parts, okay. But there is no history of chest pain or palpitations or not thinking of a cardiac cause in this child. Then
one other possibility is malnutrition because of malnutrition.
Okay. What will be the edema in nutritional edema? What is the cause of nutritional edema?
Hypoalbuminemia.
Yeah, it is because of hypoproteinemia. And what will be how will the edema be distributed in nutritional edema?
Pitting type of edema, dependent parts.
You should be in the dependent parts, okay. Then what about renal cause?
There is no history of decreased urine output.
Classically, renal edema, how does it start?
Early morning facial puffiness.
So when you say negative history, you classically say that this child did not have any early morning facial puffiness. Only after that you are going to develop your fetal edema. Then another cause?
Liver disease.
Yeah. So why are you saying it is not liver?
So I've not gone to the negative history.
No, but it is a fetal edema. You said no abdominal distension.
No abdominal distension. No other.
How will be the edema because of hepatic cause?
Initial may have abdominal distension followed by periorbital puffiness and pedalis.
So the sequence of your where it starts is more important. So from whatever she is saying, this looks like it is actually it is a dependent edema. It is only in the legs. She is ruled out. She is not thinking of a cardiac or a renal or a hepatic cause. Okay, so she possibly she is narrowing it down to a nutritional cause of edema, and all the more reason the mother says this child's appetite is less and for the last 2 months and she's lost weight. So possibly she's thinking of a nutritional cause of edema. Any other cause we'll see whether further history we'll see.
If it is tuberculosis, you are saying tuberculosis is a possibility. How will you explain the edema?
Can be cor pulmonale.
Cor pulmonale. Is it very common? We expect a child to develop cor pulmonale in tuberculosis in 1 month. It's extremely rare. Basically, remember, cor pulmonale itself is rare in pediatrics, and cor pulmonale due to tuberculosis is almost non-existent. Doesn't occur in pediatrics. I mean, they go to physicians by the time they develop all this.
Malnutrition. Protein.
Anything other than malnutrition. Suppose that mother says child is eating well, still the child is developing edema.
Any loose stools?
Tuberculosis. Your diagnosis is tuberculosis. Huh? Protein losing enteropathy. In fact, remember very importantly that you may not have diarrhea overtly in many a child who has protein losing enteropathy. They may develop edema insidiously without any other manifestation. There may be some diarrhea, some bulky stool, something like that, but children may develop edema. But tuberculosis is notorious for causing protein losing enteropathy.
One general comment, see, here also, just describe the edema. She told the negative histories, I will tell little behind. See, wherever it is necessary, you try to tell the negative histories so that it's able to tell you what is the reason for the symptom. For example, edema, if there is not associated any yellowish discoloration of eyes, if you tell there itself, it's significant, okay. And regarding that history of loss of weight, you have told. She told the history of loss of weight. What is the probable cause of loss of weight in this child?
One is poor appetite, decreased intake, and the chronic illness per se. There is also breathlessness, increased work of breathing.
So any child presenting with loss of weight, okay, what are the possibilities, what are the histories you should get? So first, what Dr. Malaysia told us, decreased oral intake. Okay, so nutrition history, that is she is going to tell us little later. One. Second is, so intake is less. Okay. Next is losses, extra losses. So have you got any history for ruling out those causes for loss of weight?
There is no history of loose stools, no history of vomiting, or no history of increased urination.
So at least gastrointestinal losses in the form of prolonged, not 1 or 2 episodes of diarrhea for 2-3 days will not cause a loss of weight. Significant diarrheal episodes or persistent vomiting for quite few period of time with reduced oral intake. That is, losses maybe because of GAT or because of renal loss, because of some renal diseases or because of even diabetes. Okay, so you should ask relevant negative histories also then and there itself. Okay.
There is no history of headache, vomiting, excessive sleepiness, or neck pain or stiffness. There is no history of any.
Why this history?
Other system involvements.
What other system involvement?
CNS involvement I want to rule out.
In this child?
Yes, sir.
Okay.
There is no history of abdominal pain, distension, loose stools, or jaundice. There is no history of rash, joint pain, swellings, backache. No history of any skin lesions, ear discharge, or redness of eyes. There is no history of exposure to TB contacts.
So now tell me, why you ask so many? Because when you are telling so many no's, okay, the examiner definitely will ask you immediately why you have told. So it's most of the histories you can even tell there itself. So now tell me one by one and tell why you have asked.
Sir, these histories I have asked to rule out apart from respiratory system, whether any other system is involved because of the disease. For CNS involvement, I have asked headache, vomiting, altered sensorium, seizures, any neck stiffness.
So which respiratory problem presenting with a chronic cough of this much duration and breathlessness will have CNS symptoms? Why you have suspected? What thing you suspected and you asked? What is in your mind? Why you asked that history?
TB meningitis.
Okay. See how common is it to this child? It's very rare. Anyway, it's not a priority. Okay. Next history.
So abdominal.
Any other respiratory symptoms? Not this case. Any child with a respiratory problem presenting with a CNS symptom. What else you have to think? Especially in adolescent children. Even the infection wise, atypical infections sometimes can present with neurological symptoms. Okay. But in this case, significance is not necessary. Then, what else?
No rash, joint pains or swelling or skin lesions.
Swelling of?
swelling of joints,
Okay.
no other swelling.
Pulled
sir.
out.
Any connective tissue disorder.
Okay. In this child, okay. Next, what else you asked?
Sir, I've asked for abdominal pain, distension, loose stools.
Ruled out.
Any abdominal involvement.
Okay. Then
no history of any skin lesions. Ear discharge. Ear or eye discharge. And no history of exposure to TB contact.
that ear discharge and eye discharge.
Yes.
Why?
Respiratory infection, sir. So I wanted to rule out any coexisting ear infection.
A child who is having a chronic respiratory symptoms, not losing weight, having a ear infections, and what else you will think? Immunodeficiency. Yeah, rather than telling an infection, immunodeficiency would occur. Probably since previously well child and acquired immunodeficiency, probably HIV is also possible. Okay. Yes. Anything else you want to add?
That's all. Sir. Treatment history for the aforesaid complaints. Child was initially sought medical attention and was treated as OP basis with oral medications. In view of non-improvement of the symptoms, child has been admitted in our hospital for the past 4 days, where some blood investigations, X-rays, sputum tests and skin tests have been done, and child has been started on multiple oral medications. Mother feels that the activity, appetite are improving and breathlessness is better. Parents are aware that child has a lung infection for which child requires treatment for a long duration. Parents have also been screened for the similar illness. Past history, Mehraj was previously well, was never hospitalized earlier, had no chronic cough, fever earlier. There was no history of previous drug intake.
Is there anything important which we have to concentrate in past history in this child? Now she's kind of, she thinks of a chronic respiratory infection, possibly a tuberculosis in this child. So if the differential diagnosis is going to be tuberculosis, or let us also think worst come worst, we have a child with a immune deficiency, an acquired or a congenital immune deficiency present at this age for the first time. So even then in your past history you are going to say that there was definitely no history of recurrent ear discharge or recurrent respiratory infections in the past, or any recurrent diarrhea, which is going to tell you that you have not ruled out a congenital immune deficiency which is presenting late, or even an acquired immune deficiency. Anything else in the setting of tuberculosis, past history, how important it is? Here you have an adolescent girl in whom you are thinking of tuberculosis. Okay. So what do you think? Is this a primary tuberculosis, or is this a, what tuberculosis is this? Has this child got exposed and got this tuberculosis now? What is the most common condition? Yeah, it is possibly the usual common cause of an adolescent presenting with tuberculosis or an adult presenting with tuberculosis, that of a reactivation tuberculosis. Okay, so you are going to say that there was definitely no history of any treatment during the early childhood period. There was no history of any primary pulmonary complex, or there was no history of any recurrent infections which warranted treatment during the early childhood period. That history is very important. And what other history is very important? What are all the conditions which can precipitate tuberculosis? Measles, any immune suppression. So you should always ask for a history of any recent viral exanthem. Okay, or this child could have basically been a malnourished child. Okay, who got a recent viral exanthem. Nothing prevents this child from getting measles at this age group. Okay, so you should definitely say there is no history of any recent viral exanthem or measles, okay, or a bronchopneumonia, or with any recent drug intake like steroid injection, which caused some immune suppression and which favored the reactivation of tuberculosis. Is that clear? So that is very important. So in a child with tuberculosis, your past history of viral exanthem, especially measles, whooping cough, any recent immune suppression is very important. Okay.
Birth history: child was first born non-consanguineous parents. Antenatal period was uneventful. Child was born with good birth weight but via LSCS. There was no history of any ICU admission. Child cried well at birth. Developmental history: child is currently going to 7th standard with good school performance. Except for the past 15 days, her school attendance and performance has been good. Immunization history: mother mother is aware of immunization only till 9 months of age. After that, she is not aware of the immunization, and BCG scar is present. So child has been immunized only till 9 months of age.
So immunization history, what is the most important history which we want to elicit in this patient? We are going to ask about history of BCG vaccination. But how important is BCG vaccination history in this patient, in this age group?
Till 5 years of age, it is important. And
what is the general protective efficacy of BCG? What is the basic aim in including BCG vaccine in our national schedule? Is it to prevent adult tuberculosis, or what is the basic?
Tuberculous meningitis, predominantly.
Right, the basic thing is it actually prevents severe forms of childhood tuberculosis. The severe forms of childhood tuberculosis are usually your
TB meningitis
and your
disseminated.
Yeah, disseminated or your miliary tuberculosis. So what is the protection efficacy of BCG vaccine?
70%.
Yeah, it is around 50 to 80%. Okay, they say it is around up to 80% in for severe forms of tuberculosis. But that even for bone tuberculosis. But does that mean that it doesn't have any role in pulmonary tuberculosis? Still has it. It gives around 50% protective efficacy against severe forms of pulmonary tuberculosis. So BCG vaccine history we are mainly asking because it actually prevents your severe forms of childhood tuberculosis. Okay. So BCG vaccine is the most important history which we would want to elicit in this patient. And the other thing, it says like you have to be more careful because here you have a mother who's not gone for regular immunization schedules and all these things. When you're talking about your treatment history and what the mother has understood about the illness, you should always put a word whether the importance of drug complaints has been spoken. Okay, it is. Don't you think it is important? It is very important in this patient because the mother has to understand the seriousness of the issue and she has to be very compliant with the medication. So always stress that point. Okay, how much she has understood and how she is going to be compliant with the medications. Okay, you can also put in a word that she knows, like if you take this medicine, the child's urine will be orange in color. Only then it's effective. All those things it adds more to your history. Okay.
In addition, studies have shown that in tuberculous meningitis, children who have a BCG scar or who have been vaccinated with BCG earlier, their prognosis is better than those who have not received BCG vaccine.
Dietary history, according to her pre-morbid diet, pre-illness diet, child was receiving 1600 kilocalories as against expected of 2000 kilocalories, which is about 80% of the expected, and 44 grams of protein against 52 grams, which is 90% of the expected. Currently, child is taking less than half of this. Her intake has drastically come down. Personal history, child has attained menarche 1 year back, has been having regular menstrual cycles so far, no dysmenorrhea or amenorrhea.
I never heard anything from you about her weight from birth and about her height. To me it's very important. Is she somebody who has always been lean, thin, who has lost weight, or she has been an absolutely healthy, chubby child who has lost weight? Does it make any difference to you?
Yes. She had been well till about 1 month back. Now,
Why is that important? How is that important?
onset of illness, sir.
One, it may tell you when the illness started. One, two,
Severity.
anybody? For example, like in a chronic disease like tuberculosis, somebody who has been underweight always fares worse than somebody who is obese. Do you see obese adolescents having tuberculosis? Very unusual, isn't it? It's always those thin ones, not that it cannot come in somebody who is well nourished. It's very important. Suppose this child has always been low in weight, it tells you that she is chronically suffering from undernutrition or malnutrition, in whom the infection, insult or the current illness has resulted in further deterioration of the illness. And very important to know about the height, because if the height had been affected, if the mother tells you she has been short, will tell you that she has really a chronic illness which has actually resulted in this infection becoming more virulent or severe, if at all, if it is infection. That's very important. Please do not forget to take history about the weight and height. In fact, if it is a CNS problem, also inquire about the head size.
Family history. She is the only child born to non-consanguineous parents. There is history of overcrowding at home. There is no exposure to pets.
What is the definition of overcrowding?
If overcrowding is defined as if there is an obligation that above the age of 9 years, people, family members of opposite sex are obliged to sleep in the same room.
Somebody is adding something.
Sorry.
The others, they are not able to hear.
Apart from husband and wife. Then no exposure to pets, birds or passive smoking or any social history. They belong to lower upper class according to modified Kupuswamy.
Why you are asking the history of pets? Which respiratory, which illness, which infection can present with cough, breathlessness of 4 weeks?
Psittacosis or
sometimes brucellosis, all these things also can present sometimes, but psittacosis is possible but rare. Okay.
Regarding this contact history, she just said a line saying that there's no history of contact with tuberculosis. So I hope all of you know that she's meaning in the last? Yeah, in the last 2 years there's no history of contact. So it is very important here, even the national guidelines or everywhere they say, like you stress a word saying that there's no history of contact with tuberculosis. There's, like, she means an open case of tuberculosis, and there's no history of any family member who has chronic cough. There's no history of any acquired immune deficiency in the family members, because if they have acquired immune deficiency, they don't have to necessarily tell you that they're on ATT, okay? They might have a respiratory infection which is possibly tuberculosis, okay? So you also say that there's no history of any acquired immune deficiency. To what extent they say that you have to say there's no history of any recent death in the family due to tuberculosis, or there's no history of any patient who was on treatment and who failed to respond to treatment, because now the most upcoming thing, most worrying thing is your MDR tuberculosis, okay? So they say whenever you take a contact history, you write all these 4 points, saying that there's no history of contact, there's no history of acquired immune deficiency, there's no history to suggest MDR tuberculosis. By MDR tuberculosis, they mean any patient who's died recently due to tuberculosis, or any patient who was on treatment and who did not show response to tuberculosis, okay? That actually raises an alarm. So you have to stress on that point instead of saying just a line that there's no history of contact with tuberculosis. And regarding that menarche, your history, so is it important in this child? It is very important, because we are talking about an adolescent girl, okay. Suppose she says that this child has not attained menarche, okay, and this child is actually crossed 13 years. She's some 13 years and 7 months or 8 months old. So what do you think? Genitourinary, you have to think of a genitourinary tract involvement. There it is a possibility, because the commonest forms of tuberculosis which adolescents can present with is, one thing is your pulmonary form where they have reactivation tuberculosis, and other common thing is your genitourinary tuberculosis. So that history is very important. Do not forget to elicit the history of menarche and how whether the cycles are regular or not. Okay.
More than that, there are two diseases which are notorious in occurring after attainment of puberty. Which are the two diseases, particularly in adolescent girls? One is tuberculosis, the other is lupus. And in fact, there had been some fascinating hypothesis that the hormonal changes which occur during puberty, not only in females but also in males, they actually impair the macrophage function. So much so that if you see tuberculosis in an adolescent, the chances of what are more when compared to younger children. Adolescent tuberculosis, what is more likely to occur in an adolescent when compared to an infant? Caseation. They blame it on the hormonal changes which impair macrophage activity, resulting in destruction of the parenchyma, resulting again in caseation. Right? And that's well accepted in literature, both in females as well as in males. Similarly, SLE is notorious.
On examination, general examination.
The other peculiar reason why adolescent tuberculosis is often very severe is that these children do not seek medical attention, social. They are all the time worried about their studies, classes, etc., rather than about their low-grade fever and a little bit of loss of weight and lack of appetite, low-grade symptom. They are more worried about their daily schedule than about their health.
History summary.
Mehraj is a 14-year-old adolescent girl, previously well, presenting for the past 1 month with cough for 3 weeks, breathlessness for 10 days, associated with low-grade intermittent fever, and significant history of loss of weight and appetite, and pedal edema for short duration, with no history of TB contact. With no history of TB contacts.
No chest pain, no orthopnea, no palpitations. So, most probably it's a respiratory system case. Number one, cough and expectoration, will you tell it is it's a lower respiratory? What is the most important symptom we have here to tell as a lower respiratory?
Fast breathing, breathlessness.
Yeah, this child has cough, breathlessness. Okay. So, which makes you to think a respiratory, predominantly a lower respiratory problem. Okay. So, it's a chronic lower respiratory problem from the history wise. Now, whether it is unilateral or bilateral, from the available history,
we cannot
able to tell. Most probably it may be a bilateral disease. Okay. Then next is whether it is airway or parenchyma or pleura.
Airway, noisy breathing, sir. There is no history of noisy breathing in this child. Parenchymal disease, because cough followed by breathlessness. Now,
so is this a pleura or not?
There is no chest pain.
This child has no chest pain but have fever and cough and breathlessness. So probably it doesn't look like a pleural pathology. Okay. So now airway and parenchyma. So this child has a predominant cough. Okay. Cough usually favors more of with this child. Okay. And fever is little. It's not a fever of 1 day or 2 days. It's a prolonged fever. Low grade fever is there. So airway and parenchyma will be the most probable localizing site. So from the history, this child
immunodeficiency with coexisting infection and
could this be an asthma?
unlikely, sir.
Why?
Sir, can be, sir. Short duration.
And they will be also having recurrent respiratory infections. What are the precipitating factors for bronchiectasis? Will any history of measles, anything is there?
No, sir.
No. Okay, then anything else? You would fever and toxicity will be the more classical presentation. Here, on the contrast, we have more cough and breathlessness. So it's less possible. Okay.
Part of multi-system.
Why do you think this is multi-system disease?
Presence of
Pedal edema. That tells you that this is beyond respiratory. Do you get edema in a respiratory disease? Do you get at all? Unless, as somebody said, carpulmonary respiratory problem. What is the other most important complaint this child is having?
she is having generalized body pains.
Body pain. Which connective tissue disorder presents with body ache?
She is unable to wake.
You must specify. Again, body ache is a very vague term.
She is unable
Which part of
to-
the body is aching? Joint is aching, skin is aching, paraplegic?
No, sir. She complains of pain over the.
Where is that pain? What sort of pain? Describe that pain. Since
So
only
over-
that we are going back.
She's complaining of pain over the both the feet,
Which part of the feet?
ventral aspect of the foot.
Ventral aspect. Which is plantar
sorry.
aspect. Plantar aspect.
Plantar aspect of the foot.
Over the bone, over the soft tissue.
Over the soft tissue.
Over the soft tissue. Soft tissue. So I will think of a vasculitis. This could well be, in fact, it would have been worthwhile to elicit history of something like a Raynaud's phenomena, where there have been changes in the color of the extremities. Because the edema, suppose the same child had given me a history that the tips of the digits had become blue intermittently and they become very red, or said there is some discoloration. What would you think of? To me, this is almost a PUO, isn't it? Or a FUO or prolonged fever, whatever you call it, whatever you want to call it. There are so many definitions. Let us not get into the brass tacks of it. Now, this is 6 weeks fever with a respiratory problem, with edema developing, with severe pain over the extremities. Now, 6 weeks fever, what are the most common causes? To me, I always remember big B and small b. That is PUO, you think of, sorry, not big brother Amitabh, big 3 and small 3. The big 3 to me are infection, malignancy, inflammation. And what are the small 3? Can anybody tell me? What small 3 mean? They are not very sinister. Okay, they'll get all right in spite of us. Can anybody give examples? I gave you examples of big 3 in prolonged fever. Infection, malignancy, autoimmune. Majority are going to fall into that. Which are the small 3s for PU? Drug fever, viral fever, third, particularly in an adolescent girl. Of course, not in this girl, I'm just telling you, it can be. Malnutrition. Malingering. Pseudo fictitious fever. Remember the 3 big 3s and 3 small 3s in PUO. Very useful. Okay. The 3 small 3s are drug fever. Is it a possible drug fever, Malishri?
There is no history of drugging.
Absolutely nothing. They have not sought medical attention. So it's not likely. Right? Number 2.
Prolonged viral.
Is it prolonged viral infection?
Unlikely, sir.
Extremely unlikely. So much of weight loss, multi-system manifestations, no rash, expectoration, not likely, isn't it? What's the third?
Fictitious.
Is it fictitious fever? Adolescents notorious, right? In fact, fictitious fever is straight away ruled out mainly because of one reason. Can you tell me one reason why you don't think of a pseudo fever? Weight loss and edema, straight away rules out. infectious. Of course, the other remote possibility is whether the child is having adolescent, anorexia nervosa, pseudo fever, then severe malnutrition, developing pedal edema, all limb pains, okay? Right? Severe multivitamin deficiencies, neuropathies, that's another. So, of the three Malessery, infection, malignancy, autoimmune, which is most likely with this history, which is least likely with this history? That's what I want from you.
Infection is most likely.
Why?
Sir.
Defend yourself. The audience votes for infection or malignancy or autoimmune in this child. Infection? Raise your hands. Okay. Malignancy? Nobody votes for. Autoimmune disease? Vedika votes for autoimmune disease. Possible. It's quite possible. In fact, all the three are possible. Why do you say infection?
Presence of a productive cough, sir, and low grade intermittent fever, and
okay, why not this be malignancy? Why not this be malignancy? And if you think of malignancy, which malignancy will you think of in a child like this? Is straight away malignancy rolled out in this child?
no, sir.
Then which malignancy will you think of?
Hodgkin's.
You think of cerebral malignancy?
Hodgkin's lymphoma.
Lymphoreticular malignancy. It can still be a leukemia. The only point against this being leukemia is that the expectoration, cough being the prominent symptom. Right? Okay. Leukemia is a definite possibility. More than leukemia, it is a lymphoma. And other lymphoproliferative disorders are quite possible. For example, you have a child with a malignancy somewhere with secondaries in the lung, complicating with secondary infection. That can go on like this. But then, from the history, she didn't give us any history of pallor, bleeding. Nothing else seems to be happening. Edema, limb pain only are there. It looks very, very unlike. See, malignancy has to be thought of. Could this be an autoimmune disease? How many of you in the audience vote for an autoimmune disease in this child? Please raise your hands. Why do you think of autoimmune disease, Vedika? Give her the mic. Let's hear from Vedika why she thought of autoimmune disease in this child. Tell me good reasons that you thought of autoimmune disease in this child.
Adolescent girl.
Very good. Adolescent girl. Obviously, yes. 1, 2.
Low grade fever.
Low grade fever.
And prolonged chronic illness.
Chronic illness.
Multi-system involvement.
Yeah, more than one system is definitely involved. Bone, something is happening. Edema is occurring. Definitely it is affecting the child's overall growth. Weight is affected. So it looks like a multi-system disease, isn't it? Fever is there, something is happening in the respiratory. This could well be an autoimmune disease. If it is autoimmune disease, which autoimmune disease would you have thought of?
SLE first.
SLE first. SLE. Obviously SLE should have been thought of, right? In fact, in medicine nothing is impossible. This could well be an SLE with tuberculosis. Can both exist together or not?
Yes.
Yes, notorious. In fact, sometimes you start ATT and the child develops lupus-like disease, isn't it? Where the anti-tuberculous drugs in themselves can result in a lupus-like disorder. So not that it cannot. Similarly, there have been reports of Hodgkin's with tuberculosis. That can also a combination of both. But of this, the most likely is infection. If it is infection, which infection are you thinking of?
Tuberculosis.
Did you think of any infection other than tuberculosis in this child? Is there any other possibility other than tuberculosis in this child?
HIV.
Other than tuberculosis, is any other infectious disease likely in this child who has got chronic cough?
HIV with secondary.
Pardon?
HIV with means acquired immunity.
HIV with tuberculosis, that is second possibility. Third, HIV with suppurative lung disease. It could well be a lung abscess. It can still be a lung abscess. Because if it is an immunodeficient child, the high fever may not be there. She may only be having cough and loss of weight, and the chills and all described in books may not be there. Right? 4.
Resistant organisms.
Persistent.
Fungal infection. Do you think this is fungal infection going on for 6 weeks? Which fungal infection would I have thought of?
Aspergillosis.
Do you think this is aspergillosis?
That sputum color is yellow.
Do you think this is aspergillosis?
No.
Why it is not? Tell me good reasons why this is not aspergillosis.
No past history. She's been well.
Remember, aspergillosis can be two ways. I mean, they can present two ways. One is so-called allergic bronchopulmonary aspergillosis, which is a disease you are going to think of in somebody who doesn't have fever, who has persistent or intractable wheeze and respiratory symptoms. This is not the case. You don't see loss of weight, you don't see edema, you don't see only cough with expectoration without wheeze at all in allergic bronchopulmonary aspergillosis. The other situation where you think of aspergillosis is a child who is neutropenic, who is on cancer chemotherapy, who has got an underlying T-cell defect. That is not the setting in. So you're not going to think of aspergillosis. Anything else? I think in this child, the other, of course, however rare it is, the other possibility that you have to think of is some rare pulmonary infections which are not responding to, of course she has not received any treatment at all, isn't it? She has not received treatment at all. If she has been receiving some treatment, what will you think of?
Drug resistant organisms.
Which organism resistant to what? Pneumococcus?
Atypical organism.
Which atypical organism which will cause 6 weeks of fever, weight loss and cough with expectoration?
Pneumocystis.
Yes, pneumocystis. Does it cause expectoration like this? No. And pneumocystis, can anybody tell me why pneumocystis is not a possibility in this child?
Hypoxia is not.
Hypoxia. 6 weeks it is going on and even now the child is not requiring oxygen. Is that right? So that makes it extremely unlikely. What other organism? Name two organisms which are notoriously implicated in chronic respiratory symptoms or pneumonia?
Mycoplasma.
Nocardia and Burkhardia. These are the two things. Nocardia and Burkhardia. And myelidosis. Myelidosis is one diagnosis you have to think of. Of course, in this child it doesn't have manifestations outside the respiratory tract. These two are notorious, but they don't occur unless there is some immune defect like CGD or something like that. But that's a remote possibility as you keep in mind other than tuberculosis. Right? Okay. So with the history, she says that it is probably a chronic infection, respiratory problem. She thinks it is tuberculosis. Of course, she thinks the edema is probably because of poor intake and it's a nutritional edema. She was unable, of course, with the pain in the limbs, she was not sure what it is caused by. With cachexia, loss of weight, adolescence, she thinks she has tuberculosis, pulmonary tuberculosis. Is that right? Okay.
On examination, a child is looking chronically ill, malnourished. She is tachypneic, not requiring any oxygen support. She is alert, oriented and interacting well. Vitals, respiratory rate is 44 per minute, regular. Heart rate is 88 per minute, which is regular, normal in volume and character. BP is 102/60, recorded in the right upper limb, supine position. Child was afebrile at the time of examination. There is pallor, no cyanosis, clubbing, icterus or lymphadenopathy. There is bilateral pitting type of pedal edema. There is an IV line in situ on the left dorsum of the hand, and BCG scar is present. Mantoux mark was present, which was so far negative. On head to toe examination, eyes, ears, nose, throat, oral cavity normal. There are no scars or sinuses. Spine appears normal. Anthropometry, child's
So your general examination, she feels this is a chronically ill-looking child who is cachexic. Did you use the word cachexic?
Malnourished.
Child who is malnourished. So
Chronically.
even before the child comes, we should be able to imagine from whatever she is going to say. So she is a child sick-looking. Chronically sick-looking child. Okay, sick-looking child who is malnourished and
tachypnic, not on any oxygen support. She is alert, oriented, and interacting well.
Okay, and the only significant finding is that she has a pallor. Is it mild pallor or
mild pallor?
She has mild pallor and she has pitting bilateral feeder edema. Okay. Head to foot examination, she said that there is no significant lymphadenopathy, no scars, no sinuses. What else in head to foot? The most important thing is the BCG scar and the Mantoux mark, which is negative. Okay. What else do you want to say? Now that she's been talking about tuberculosis for a long time. Clubbing, she said there's no clubbing, there's no cyanosis. What are all the external markers which you can find in a child who has tuberculosis?
Then,
so before, instead of just saying that the eyes are normal, you can always say, mention that there's no cutaneous marker, there's no cutaneous marker, there's no flictanular conjunctivitis. Cutaneous marker, what do you expect when you have a child with, what form of tuberculosis? Disseminated tuberculosis. What will be the cutaneous marker?
Lupus vulgaris.
Okay. Commonest, what do you find?
Scrophulodderma.
Scrophulodderma is an extrapulmonary form of tuberculosis. I am talking about cutaneous. What would you see?
Nodules.
Erythema nodosum. Okay, that is the most common thing which we generally find. Where do you usually find it?
Shin.
It's over the shin. Okay, so erythema nodosum, then? Okay. You finish off the examination.
Anthropometry. Weight is 30 kgs. Height is 158 centimeters. BMI is 12, which is below the third centile for the age. SMR, there is no axillary hair, but child could not be undressed for further classification. On examination of respiratory system, upper airway, nose, ear and oral cavity is normal. There is no sinus tenderness. Neck veins, there are no distended neck veins. On examination of chest inspection, child is tachypnic. Respiratory rate is 44 per minute, which is regular. There is no obvious shoulder drooping. Trachea appears in midline. Back is normal. Movement of chest appears symmetrical on both sides. Shape of chest I could not appreciate because I haven't undressed her completely. On palpation, trachea is in midline, apex is in 5th intercostal space, medial to the mid-clavicular line, half an inch medial to the mid-clavicular line. Chest expansion is reduced on the left side. It is 3 centimeters compared to 5 centimeters on the right side. Percussion. On percussion, dull note is appreciated over the right infraclavicular and inframammary and left inframammary and infraaxillary areas. Other areas are resonant. On auscultation, bronchial breath sounds are heard over right upper, right infraclavicular, right inframammary and left
Is there cyanosis in this child?
There is cyanosis and
Is it central cyanosis or peripheral? Is it central cyanosis or peripheral cyanosis?
peripheral cyanosis.
Central cyanosis.
Peripheral.
Why? Why?
The other
She has been sitting in the AC room and probably in the AC room, neighboring room, that the extremities have become cold. She has a mild cyanosis, and in the absence of clubbing in the absence of polycythemia, clubbing, and of course, Malesri has checked the saturation. What is saturation?
9.
If it is warm, it might be central, and if it is cold, it's very much likely to be a peripheral cyanosis.
On auscultation, bronchial breath sounds are heard over the right infraclavicular, right inframammary, left inframammary and left infraaxillary areas. Bilateral crackles are present in both right and left int-oriented to time, place and person. There are no neurological deficits and no meningeal signs. CVS, both first and second heart sounds are normal. There are no added sounds.
Anything is significant?
No, sir. I percussed, sir, there is dull note to be increased on the right, similar right infraclavicular.
Wherever you heard bronchial breathing, you got an increased vocal resonance. Any adventitious sounds are there?
Bilateral crackles are present.
Where?
Right and left inframammary areas.
What's the type of bronchial breathing you hear here?
Tubular.
Tubular.
Above the medial malleolus, the skin is pressure is applied over the skin and gradually released and observed for the pitting. Dry, shiny.
Do you think it is necessary to check? What other observation is very obvious when you inspect the child?
There is muscle wasting. She is thin built. Muscle wasting is present.
Remember, when you are describing in the general examination, it is very obvious that she is almost marasmic, isn't it? You need not use the word marasmic, but you must describe in the physical examination that her skin is wrinkled. Hardly there is any muscle. In fact, if somebody has got a tape, just measure her mid-arm circumference. Of course, not necessary, just out of curiosity. Measure the mid-arm circumference of this child. I am sure it won't be more than 15. Left side. I am sure it won't be more than 15 or 16. Maximum 15, don't be. Yeah, definitely. But you could have demonstrated that she has severe muscle wasting. You need not measure the mid-arm, but you could have mentioned that there is severe muscle wasting. The presence of edema in the presence of muscle wasting, what is the importance? That tells you that this edema is not renal. Particularly when there is no facial edema, no ascites, no cardiac findings, right? It's very significant that her nutritional impairment is so severe and obvious that you should not miss these findings. BMI is 12, obviously.
And she is having obvious muscle wasting with bilateral pitting edema, and on pallor is present. On examination of respiratory, no generalized lymphadenopathy, no organomegaly, and spine is normal. There is a BCG scar and manto is negative so far. Intermittent fever with bilateral pitting edema on with no history of TB contact, both right and left, right infraclavicular, inframammary and left inframammary areas.
Dr. Malleswari, what is the anatomical and pathological diagnosis in the lung? You had some findings. What do those findings suggest?
So, consolidate.
How do you distinguish a cavity from a consolidation clinically?
Clinically, vocal resonance.
Basically, the difference between a cavity and consolidation originally described have been in cavity you